Hello, I'm Katerina and I'm a cosmetic and restorative dentist.
Hello, I'm Manuel. I'm a dental surgeon.
And today we are here to present you a webinar with the title C-Tech Guided Surgery and Prosthetic Solutions from Posterior to the Aesthetic Zone. We will show you different clinical cases and you will understand how using guided surgery and the different prosthetic solutions that C-Tech offers, you can do all type of different cases from simple to complex, from posterior to the aesthetic zone. So the first case we will present is a 40-year-old woman that presented to our dental clinic with the chief complaint being difficulty in eating and also poor aesthetics. Here you can appreciate the initial extraoral photographs of the patient. Here the close-up of the smile, first with lips at rest, then social smile and maximum smile. Here we can see the initial intraoral pictures of the patient in a frontal view. Here lateral and occlusal view, and we can see absence of several teeth on the maxillary arch, dental caries and failed old treatments.
So, going into the panoramic X-ray, we can appreciate generalized bone loss. So, as you can see, both aesthetics and function were compromised. Before making a decision on what teeth we should maintain or extract, we do a periodontogram. And even with the hopeless teeth, we have to do scaling and root planing so that we can achieve some reduction of the inflammation and reduce bacterial colonization. Here we have the charts for the upper and lower teeth. You can see that upper ones have very deep pockets with furcation on the molars, while on the lower ones the situation was much better. To be able to propose a treatment plan adequate for the patient, we need first to understand which teeth we could maintain and which teeth we should extract. These two articles summarize the critical factors in deciding whether a tooth should be treated and maintained or extract and replaced by dental implants. In this case, all upper teeth were considered to have unfavorable long-term survival, with extraction recommended. Regarding the lower, all teeth but the 47 were considered to have favorable prognosis. The tooth 47, although with a questionable prognosis, was decided to maintain, as according to the literature it could be successfully treated by non-surgical mechanical debridement. Now let's talk a little bit about the prognosis of implant therapy in perio patients. It is described in the literature that microorganisms found in periodontal patients can colonize the implant surface and infect peri-implant tissues. For that reason, it is essential to understand if the prognosis of implants in periodontal patients is comparable with the same treatment in healthy patients. These articles report, although slightly lower, very similar survival rates for implant placed in periodontally compromised and periodontally healthy patients. Additionally, it is reported a slightly higher marginal bone loss around implants in periodontally compromised patients. Nonetheless, survival rates of implants can still be considered high in perio patients, given that, although with caution, as long as adequate control of periodontal disease occurs previous to the implant placement and the implementation of an appropriate maintenance program, we can expect favorable outcomes.
Okay, so then jumping to the implant supported restoration, according to this article from Blasi and colleagues, success and long-term stability of implant-supported zirconia full-mouth restorations can be achieved when important parameters are followed in detail, especially the treatment plan, the framework design, and occlusal considerations. Depending on the material selected for the restoration, there is more or less need of interarch space. When using zirconia, there must be sufficient space based on interarch position in the mouth, the distance between supporting implants, the presence of cantilever, and likely occlusal loading. Regarding implant number and position, Blasi and colleagues recommended to have 8 implants well distributed within the maxillary arch, especially when opposing natural dentition. And the approach goes as follows, and you can see on the image on the center of the screen. First, one implant is placed in the most anterior position on the arch and 2 implants in the most posterior area. Then, one implant is placed as close as possible to each of the 3 implants already in place, and these are the safety implants. And finally, one implant is added per side between the 2 anterior implants and the 4 posterior implants, of course if there is enough space. This will reduce pontic numbers and also the stress during function. Okay, so if there is 12 millimeters or less from the desired incisal edge to the bone crest, an implant-supported fixed prosthesis with no pink should be fabricated instead of performing aggressive vertical bone reduction. Here we can appreciate with the measurements we did on the planning software that we have around 12 millimeters, so we should proceed with the prosthesis without pink ceramics. Okay, then regarding guided surgery and immediate loading, which we are planning to do in this case. Guided surgery permits backward planning to optimize the implant and prosthetic result, improving the safety and efficiency of the surgical procedure and rendering the restorative outcome more predictable in terms of function, biology, and aesthetics. In this book, Fixed Restoration, the authors affirm that the 3D position of the implants should depend on the restoration and not on the availability of local bone. Also, the guided surgery approach will optimize implant position, angulation, and depth. Regarding immediate loading, it is a treatment approach that has been favorably reported in the literature with high success rates. Fixed interim restorations provide patient comfort while maintaining the vertical dimension of occlusion and allowing soft tissue management. So this is the current situation of our patient, and the treatment plan proposed was: first, treat the active periodontal disease with scaling, root planing, and oral hygiene instruction, then extraction of the hopeless teeth, and placement of 8 implants on the upper, 1 implant to replace tooth 36, immediate loading of the upper implants with a fixed provisional prosthesis. And regarding final prosthesis of the upper, because the patient has low functional risk, we proceeded with a combination of zirconia framework with layered feldspathic porcelain. Also, it was included in the treatment plan a screw-retained zirconia crown for 36, and finally an occlusal splint. So, besides the initial intra and extraoral photographs, we took an initial intraoral scan, CBC and CBCT to be able to perform a proper planning of the case. Then I used the 2D Dental CAD software to obtain a virtual smile design, taking into consideration important facial references such as the midline, verticality, and smile line. An important thing when planning a full arch rehabilitation is the dimension of the central incisors. To obtain appropriate dimensions, we should take into consideration patients' tooth display at rest and also during smiling. Also, it is well described in the literature that maxillary central incisors should have 75 to 80% width to length ratio to generate an aesthetically pleasing smile. This information, together with the initial intra and extraoral photographs, STL files, and the 2D smile simulations, were sent to the lab to be able to produce a mock-up. And this is the 3D printed cast translating the 2D diagnostic waxing. Then a silicone index was obtained from the 3D printed model and filled with bisacryl resin to produce trial restorations and evaluated 2D smile planning on the patient's mouth. These here are the pictures of the patient with the mock-up, and these are the extraoral pictures of the patient also with the mock-up. This 3D planning previous to the surgery allows anticipating the prosthetic outcome. We approve the mock-up and the patient as well and use it to plan the guided surgery, resulting in a prosthetic-driven orientation of our implant positions. In this picture, we can see the comparison between the initial situation of the patient and of the patient with the mock-up.
So, to plan the guided surgery, first we need to superimpose the preoperative intraoral scan with the CBCT as well with the data from the WhatsApp using an implant planning software. In this case, we used RealGuide. After this, the actual process of prosthetic-driven implant planning can begin. The digital planning of the implant is based on in the anatomical situation and previously planned prosthetic restoration. After the implant planning has been finalized and approved, the surgical guide was designed using the same software. The guide was then 3D printed. Now I will show you the exact planning for each implant, besides the molars. For the molars, to be able to have a teeth-supported guide, we have decided to go for immediate implants not guided. So here you have tooth 13 for all implants except the 25, which is a 3.8 per 11 millimeters implants. Tooth 13, 11, the 21, 23, and here you have the 25. On 25 we choose to place a 3.8 by 9 millimeters. This is our prefabricated interim prosthesis, fabricated according to the previously approved mock-up. Then the provisional restoration was milled from a PMMA disc. This is the 3D printed surgical guide and the 3D printed model obtained after the virtual extraction of some teeth. Also, here we can check the proper fitting of the surgical guide on the 3D printed model. So after this we can go for the surgery. We start by the traumatic extraction of the hopeless teeth in order to maintain the volume of the hard and soft tissues to increase the future implant success. You have on the right side the post-extraction sockets. You can see that the buccal plate and soft tissue architecture was preserved. And note that the tooth 12 and 22 were provisionally kept to increase the stability of the surgical guide. We go for the posterior zone, and on the premolar region of both quadrants we make a palatal incision to raise a full thickness flap and mobilize the keratinized tissue from the palate to the buccal side in order to increase the soft tissue volume around our implant. And this is the guide in place. Here we can verify the fitting and the stability of the guide on mouth and start by placing our fixation pins. This will help to have a better stability of our guide. And then after this we can start by the drilling. We go in the insertion of the drills through the guide for the implant preparation and do the drilling protocol. And go and start to place the implants. This is the guided implant placement. And then you can check the marks on the implant carrier matching the surgical guide sleeves. And this confirms and gives you the confirmation that the implant is in correct position. On the right side, you can see both implant carriers demonstrating the favorable implant position. This is the occlusal view of the implant position. And you can note on the right side the subcrestal position of our implants. So here all 6 implants we plan to use have adequate primary stability exceeding 35 newtons of torque. So after this we can start and place the multi-unit abutments.
Okay, so after Manuel placed the multi-units, I attached open tray impression copings to the abutments and did the full arch impression to be able to have the provisional immediate restoration. Then I placed 3 temporary titanium abutments over the multi-units and attached that interim prosthesis to the temporary abutments using, in this case, tooth color acrylic resin.
And here we have a small video of our surgery. You can see the planning. We put the planning to know what we have to do. Already the guiding place, you didn't see the extractions, and we go for the drilling protocol. We go drilling for the implants on the tooth 11. And after the drilling is done, we go and place the implant. What I like to do is I place first the implants. I don't like to drill in all places, and just after I place the implants, because this way, if I place right after the drilling the first implant, I can see how is the primary stability of the first implant, and with that try to make sure that we have a good stability on our all implants and can load
can adjust some parameters
and have immediate loading for our provision. So the provisional and that's it.
Okay. So this is our provisional restoration, already finalized and polished by our dental technician in the same day of the surgery. Here you can see the intraoral pictures of our provisional PMMA fixed prosthesis delivered immediately after surgery, screwed on the multi-unit abutments. The occlusion was verified to make sure that we had well-distributed contacts, no interferences nor perimeter occlusal contacts, and the patient was advised to maintain a soft diet. Here you can see the post-operative panoramic X-ray and appreciate the proper fit of the provisional prosthesis. Implants 16 and 26 were not loaded because they hadn't enough primary stability. Once on those regions, the patient bone had very low density and they were placed on post-extraction sockets. This is 1 week follow-up picture. We can note the favorable healing and proper soft tissue architecture. Some more pictures of the intraoral situation after 1 week after the surgery. And here a comparison of preoperative situation on the left side with the situation 1 week after the surgery on the right side. This was the situation 3 months after the surgery. Here 4 months after the surgery, and also 1 month after the second stage surgery on the implants 16 and 26. Another picture, and here we can note the proper soft tissue architecture and presence of interdental papilla, which will be very good for the final result of our prosthesis. Here we can see patient still with her provisional fixed prosthesis, also 4 months after the surgery. We use these extraoral pictures also to plan the final restoration because they give us important information on things we consider correct in terms of statics and things that we will want to change for our final prosthesis. It helps also with patient and lab communication. So at this point of healing, we go ahead with our final impressions. In this case, we use the conventional impression technique. Nonetheless, we also scan inside and outside the mouth the provisional prosthesis because this gives important information to the lab technician and that will facilitate the process of obtaining the final restoration. Here we can appreciate the final restoration, the zirconia restoration without pink ceramics. Some more pictures of the final restoration on the model. And this is the final intraoral picture of the patient. Some more intraoral pictures of the final prosthesis. Close-up. Another close-up. Here the close-up of the smile. Here we can appreciate the comparison between initial situation and final result. And last but not least, the final panoramic X-ray that confirms the proper fit of our final prosthesis. As you can see, from our initial plan is missing the dental implant to replace tooth 36. However, This is because the patient asked us to postpone some months due to financial issues. Okay, so the next case we will present is a 30-year-old man that came to our practice with a chief complaint that needed to replace some teeth that were missing in his upper jaw because that was interfering with his chewing ability. And these are the initial intraoral pictures of the patient. We can see absence of 24, 25, and 26. And the treatment plan proposed was the placement of 2 implants, followed by the placement of immediate final abutments at the same time of the surgery. In this case, we chose one-time system. And the planned final procedures was a 3-unit bridge over implant. So the one-time concept refers to the placement of final abutment immediately after implant placement, thereby eliminating the need for multiple implant abutment disconnections. Several authors have been reporting that a repeated abutment disconnection might produce biological and microbiological damage to the tissue abutment implant complex, which considerably increases peri-implant marginal bone level changes. So by placing the final abutment at the time of the surgery and not removing it anymore, we avoid disruption of the soft tissue seal around implants and therefore increases its stability and led to better preservation of marginal bone around our implants. So continuing with our case, as for most of our clinical case, we took a pre-operative intraoral scan to plan the guided surgery.
So, once the implant position were defined in our planning software, they were translated into design of the surgical guide and printed. And here you can see the photos of our guide. So when we have our guide ready, we go for the surgery, and at the time of the surgery, the stability and adaptation of the guide were checked, and we used the CTEC guided surgery to drill and place the implant. Here you can see the drilling protocol for the implant on to 4. And for that implant, we choose a 3.8 per 9 millimeters. And for the implant of the 26, we place an implant of 4.3 per 7 millimeters. So both implants, 24 and 26, were placed fully guided. And here we have our implants in its final position. We can come back.
Sorry.
For this type of surgery, I never do with the punch. I always open a flap because I think it's much better to preserve the maximum of keratinized tissue. So it's because of that I do this full thickness flap. And then we place the one-time abutments with the 3 millimeters of gingival height, and they were seated on the 2 implants. And we fastened with the cover screw, which works also as the healing abutment. And to achieve a better soft tissue aesthetics, I made also a connective tissue graft on this zone. And here you can check the implants in their final position on very parallel to each other in order to have a better specificity of our final restoration. That thing, having this kind of parallel implants, it's only possible when you do guided surgery, okay?
These pictures are 3 months after the surgery. We can observe a good healing of soft tissue around the one-time abutments. On the left side of the screen, we can see the cover screw still over the abutments, and on the right side, we see the one-time abutment without the cover screw. After the osseointegration period, we proceed with the final impressions. First, we remove the cover screw and then we attach the tie base over the one-time, never removing the abutment itself. This is the concept. This is our patient already with the tie base over the one-time abutment. Then we place the scan caps over the tie bases to do a digital impression with the intraoral scan. And this is a video of the final impressions. First time placing the tie base over the one-time. Then I click the scan caps and finally proceeded with the impression. First I scanned the caps and the other upper teeth. conclusion. Here you can see the impression completed, and this file is after sent to the lab. Here you can appreciate part of the laboratory workflow. First, the lab technician is producing the 3D model, and then she's placing the analog. These are some pictures of the 3D model printed and already with the analogs. And this is another step of the laboratory workflow. In these restorations were obtained using CAD/CAM technology, and this is the video of the design of the bridge and then the bonding of the bridge to the tie bases. Okay, we see now the bonding of the bridge to the tie bases on the model. And here the final restoration on the 3D model. The material is monolithic zirconia. This is the final result of our treatment. We can see frontal picture, lateral view and occlusal view. Here we can see also the X-rays of the final restoration. And here the panoramic X-ray with the final restoration on the second quadrant, which is a bridge over the one-time abutments. Okay, the next case we will present is a 67-year-old woman that presented to our dental office with pain on the first quadrant. Here we have the initial intraoral photograph of the patient and also her panoramic X-ray. The clinic and radiographic examination revealed extensive caries and a history of root canal therapy failure on teeth 13 and 15, also absence of teeth 14 and 16. In this case, the treatment plan proposed involved the extraction of hopeless teeth 13 and 15, and the placement of 3 implants, followed by the placement of immediate final abutments at the same time of the surgery, so again, the one-time system. The planned final prosthesis consists of a single crown and a 3-unit bridge over implants. Besides photographs and CBCT, an initial digital impression were obtained using an intraoral scanner. The intraoral scan and CBCT were superimposed using a specific 3D CAD software to plan implant placement and design the surgical guide.
So, after the final position of the implants was decided on the planning software, we printed both the guide and the model so that you could check the fitting before the surgery. So in this case, we are going to put an immediate implant on the tooth 14. So we didn't go for flapless surgery again. So we extracted the roots, opened the flap, and after that we can check the fitting of the guide. Then we go for the guided drilling protocol and placed first the implant on the tooth 14. As you can see in the photographs, I placed on implant 14 an anchor stent over the implant in order to achieve a better stabilization of the guide, and only after that I proceeded with the drilling protocol of the other 2 implants. You can see there.
You can see here first the 13.
Here the 13 and here the 16. And after the implants were in their final position, we go to place the one-time abutments and we suture the surgical site.
And then again, 3 months after the surgery, we proceeded with the final impressions, as in the previous clinical case in which one-time system was also used. First, we removed the cover screws, then we placed the titanium bases over the one-time abutments, and finally scan caps were attached to the tie bases to do the digital impression. And this is our digital impression. In this image, you can better visualize how the digital analog is placed on the 3D model and which kind of screws you should use for each part of the system. Here you can see the final restoration. They were fabricated using CAD/CAM technology again, and the material chosen was also the same as in the previous case, so monolithic zirconia. Here you can appreciate some photographs that illustrate the progression of the treatment. First the initial situation, then the one time with the cover screws, then the one time without the cover screws, and finally the definitive restoration. These are the intraoral final pictures of our case. Then also the final periapical x-rays to confirm adaptation of the crowns. And that's it. So we'll go for our fourth case. And this case is a 66-year-old man that presented to our dental clinic seeking a fixed restoration to replace his terminal dentition. This is the initial extraoral picture of the patient. We can start to see that he shows very little teeth when he smiles. Here in the initial intraoral pictures, we can notice the absence of several teeth, also generalized tooth wear and bad oral hygiene. Also aesthetics in general was very compromised. This is the initial panoramic x-ray of the patient. The intraoral and radiographic examination, panoramic, periapical x-rays, and CBCT revealed partial edentulous arches, the presence of periapical infection and extensive carious lesions on several teeth, significant attachment loss, and tooth mobility. Also, the vertical dimension of occlusion was reduced due to loss of posterior support and excessive wear. So following a proper diagnosis, the treatment plan proposed for this patient was the extraction of all the remaining teeth, placement of 5 implants in the maxilla and 6 implants in the mandible, immediate loading of the implants, and as final restorations, full arch screw retained prosthesis over multi-units on the upper arch and over omni abutments on the lower. On the mandible, the patient exhibit less soft tissue thickness, so that's why we selected the omni abutments as prosthetic components. The omni have smaller diameter than the multi-units, 4 mm diameter versus the 5 mm of the multi-units. Also, it is important to mention that prior to implant placement, a decontamination of the deep pockets was carried out. This is the initial intraoral scanner of the patient. We use the scanner together with photographs and CBCT to be able to do a proper planning of the case. The first part of the preoperative prosthetic planning is a 2D facial-driven smile simulation. I send these files to the lab technician so she can translate the 2D simulation in a 3D mockup. With a 3D printed mockup and the silicone index, we can try the previous plan design on patient's mouth. Both us and the patient approved this try-in, so it was scanned and superimposed with a preoperative intraoral scan and CBCT to digitally plan the implant surgery.
So, due to the patient's systemic condition, it was decided to perform first the upper surgery and 3 months after the lower one. In the upper arch, after the extraction of all maxillary plus teeth, implant sites were prepared through the guide according to a specific drilling protocol. In this case, we used the CTEC guided surgery kit and followed by the implant placement. All implants were torqued with at least 45 newtons of torque to ensure enough primary stability for immediate loading. After the implant placement, multi-unit abutments were inserted and torqued in place with 25 newtons of torque. Then a full arch provisional screwed restoration was delivered the same day. Here you can see the intraoral picture of the patient after surgery of the maxilla. So, 3 months after the upper surgery, we proceed with the lower surgery. In this case, the guided surgery and the Omni abutments were planned on a specific software using the CBCT and the STL files from the intraoral scan. The superimposition of these files allow us to plan with a greater accuracy the implant position, which implant to use, and the length of the Omni abutments. Also, in this case, to improve the precision of the surgery, 2 surgical guides were used. The guide 1, it was designed without any digital extraction. And then we go for the guide 2, and it was designed after the extraction of all teeth except the canines. So the guides are prepared, we can go for the surgery, and here you can see the first guide. This guide was placed before any extraction, as I talked before, and it was used to plan all implants on the molars and the right premolar region. And after the placement of these implants, this guide was removed, all teeth except the canines were extracted, and then the second guide was seated and used to place implants on the anterior zone and on the left premolar region. After all implants were in position, we made some regularization of the bone. And after implant placement and regularization, we go and place the Omni abutments with 25 newtons of torque and sutured.
So after that, and to be able to deliver a provisional fixed prosthesis on the same day of the surgery, I did a full arch conventional impression over the Omni abutments of all implants, and also placed 3 temporary titanium abutments over the Omni and attached the interim prosthesis to the temporary abutments using acrylic resin. Finally, a full arch provisional screw restoration was delivered, and here you can see the occlusal picture of the lower jaw with the provisional prosthesis. And this is the panoramic X-ray with both temporary fixed prostheses. Here we see the intraoral pictures of the patient with the immediate fixed temporary prosthesis on the upper and lower jaws, and also periapical X-rays confirming the adaptation of the lower prosthesis to our Omni abutments. Here we can see some extraoral photographs of the patient with the provisional prosthesis, already a big improvement in terms of aesthetics of his smile, we can note. And then 3 months after the lower and 6 months after the upper surgery, we proceeded with the final impressions. In the occlusal view, as you can see here, after removing the lower fixed provisional, we can appreciate a healthy appearance of the soft tissue around the Omni abutments. Here we can see a video of the final impression of the lower jaw. And finally, we delivered in the upper arch a full arch screw-retained fixed prosthesis over multi-unit abutments, and in the lower a full arch screw-retained fixed prosthesis over Omni system abutments. And this is the final extraoral situation of the patient. These are the final intraoral pictures. And here we can see the final panoramic X-ray confirming the proper fit of our final prosthesis. Finally, we can appreciate the comparison between the initial and final situation of the patient. And the last case we will present today is an immediate implant with immediate loading in the aesthetic zone. This patient presented to our dental clinic very unhappy with the aesthetics of her smile. She said that her front teeth were always misaligned, but recently they had worsened considerably. Here we can see some of her initial extraoral pictures. Already we can start to understand why the patient was not satisfied with her smile. Note the position of the right central incisor. These are the initial intraoral pictures of the patient in a frontal view. Here lateral and occlusal views. And in a close-up, regarding smile analysis, we can appreciate that the proportions and shape of her teeth, especially the incisor, are not aesthetically pleasing. Also, she had a lot of space between the interior teeth, which obviously compromised the aesthetic of her smile. The periapical X-ray revealed that tooth 11 had very little bone support, and also clinically we detect grade 2 mobility. This is the initial panoramic X-ray of the patient. So, following our diagnosis and given the fact that the patient asked for a minimally invasive approach, we proposed the following treatment plan: prophylaxis, direct composite restorations on teeth 12, 21, and 22 to help managing the interdental spaces and improve aesthetics, extraction of tooth 11 with immediate implant placement and immediate loading, and finally a ceramic crown over implant. As for most of our cases, we took an initial intraoral scan to aid on planning of the final restoration and guided surgery.
So, after getting the STL file from the intraoral scanner and the DICOM from the CBCT, we advance for the planning. First superimposing the files, and then we decide which implant to use and its position. In a case as this that we have to replace a central incisor, we have to be sure of the position of our final restoration and then guide the position of our implant by it, doing it prosthetically guided. To do this, we extracted the tooth from the original STL and made a digital WhatsApp using this to guide our surgery. So, we go for the surgery, and going for the surgery we start by an intrasulcular incision with a microblade in order to be minimally invasive, after that we do an anatomatic extraction with the forceps. You can see here that we preserved the two papillas, and the next thing we made was tunnelize the vestibular flap in order to have space to place a connective tissue graft. And this is the guide placement and checking its fitting and stability, you can see. Then, after the guide being in place and stable, we can go for the drilling protocol. And then we place the implant fully guided. So, why did we use this kind of implant? The EL from CTEC in a post-extraction socket. Because we have an apical portion that has aggressive threads that will help us to achieve a good primary stability, essentially in immediate implants if we want to load them, and then the coronal part is less aggressive. This will not make so much compressive forces on the cortical bone that is less vascularized, and this will allow us to have less bone resorption and to preserve the bone peaks. So here you can see the implant in its place, and you can check that it's palatally placed as we planned. So after the implant is in its place, we go for the soft tissue management, and in this case we decide to go for a connective tissue graft from the tuberosity, and the connective tissue graft will allow us to have a better peak aesthetics outcome short and long term.
Then, to obtain our immediate provisional restoration, we use the provisional titanium abutment and the patient's own tooth. I cut the root of the tooth and prepared the crown to bond to the provisional abutment. This is the occlusal picture at the end of the surgery. And here we can see an intraoral picture 1 month after the surgery, and also the periapical X-ray of the implant with our provisional restoration. Using the previous X-ray, we can highlight important prosthetic features of the EL implant from CTEC that not only favor good results in these kind of aesthetic cases, but are also very important for all types of cases. First, the concave design of the abutments, which will help with soft tissue aesthetics because it will make more space for our tissue to grow. Then, the platform switching, which is using a prosthetic abutment that at the point it emerges from the implant is smaller in diameter than the implant platform. This feature places the gap between the prosthetic component and the implant away from implant shoulder, thereby helping long-term stability of the bone. Also, it helps with preservation and stability of the soft tissue. This is not only very important for aesthetics of the final restoration, especially in the anterior zone, but also, accordingly to several authors, may be considered as having a significant influence on marginal bone stability and long-term survival of the implant. The Morse-locking conical connection and index eggs are other important features of this implant. They will reduce screw loosening and micro movements of the restoration, which is mandatory for immediate loading. We need a very stable connection not to interfere with the osseointegration process. Also, it will be very important later when the final restoration is placed to avoid mechanical problems with our prosthesis and for the long-term survival of the implant. Note also the subcrestal position of the implant, ideal for the aesthetic zone, once it allows proper emergency profile of the restoration over implant and helps with long-term aesthetic stability. Okay, so to optimize the time, we decided to go ahead with the direct composite restoration while we waited for the osseointegration of our implant, and the first step is shade selection. Then placing of the rubber dam and proceeding with the direct restorations. This is the immediate result right after removing the rubber dam. And here's a video where you can see how I modified the shape and managed the interdental spaces, comparing the picture right after the surgery and after the composite restorations. Later, 3 months after implant placement, we proceeded with the final impressions. I scanned also the current situation of the patient and her provisional crown. With this information, the lab technician will be able to better reproduce the critical and subcritical contour of our restoration. And this is a close-up of the final result on a frontal view, lateral view, final intraoral pictures and smile, comparison of the initial and final situation, also before and after pictures in a lateral view, frontal view, and that's it.
Yeah, that's it.
That concludes our webinar.
Yeah, thank you so much for watching. Hope you enjoyed it. And you have here our emails. If you have any doubt, you can contact us, and if you need anything.
Yeah, thank you so much.
Thanks for watching. Bye.